what their relatives' needs are and then help connect them to services. So that could be at home with assisted living, some home, and we'll talk more in detail about that as we go on.
Hi everyone, thank you again, so happy to be here. Again, my name is Megan Nelson. I'm a licensed master social worker here in the state of New York, and as Carrie mentioned, I've been working with the Family Caregiver program at Heights and Hills for the better part of the last decade. Our program is really cool. We are funded under contract by the City of New York to provide free social work services to family caregivers of older adults. So our team of social workers is here to offer assistance, information, supportive counseling. We organize support groups for caregivers. We do workshops and trainings. Also are in some cases able to offer a little bit of respite care to give caregivers a break from the hands-on work of caring for their loved one. I think my position, Steve, you and I kind of share the unique position of being able to encounter and support caregivers earlier in the process of thinking about end-of-life issues. Folks come to us and they're concerned about their loved one. Maybe they're feeling a lot of stress about caregiving. They may not even have on the horizon the idea of their loved one's last days. But as we work together, as we build that relationship, and as time goes by, we as social workers get more and more opportunities to start having those conversations with our clients. And a lot of times it begins as having conversations about planning ahead of time. So I'm not sure, Carrie, do you want to start in with the questions? Or?
Yeah, why don't you keep that mic grant down there and we'll share this one here. Yeah, so we got some questions online in advance, so we'll go through some of those, but I'll also make sure that we save time at the end for questions for those watching and those present. Hard to know where to start. Why don't we start actually with the difference between palliative care versus hospice?
That's an excellent question. Palliative care and hospice, palliative and hospice are two different things in a way. But more I would think of palliative care as being a large umbrella and hospice as being a smaller umbrella within palliative care. So an example could be a patient who is elderly, who has, let's say, Alzheimer's, dementia, is diagnosed early on in their illness, and they may be seeing a palliative care physician for some symptom management, advanced care planning, and quality of life work. And they may be working together for 10 years. And patients comes to the final 6 months of their life because of increasing infections, poor eating, breakdown of their skin, and there was a conversation between the palliative care team, the social worker, the physician, the doula, kind of talking about the prognosis with the family and speaking about eligibility for hospice. So hospice is a medical services provided to patients who may be in the final 6 months of their life. So I would think of hospice as the final bit where you have an intensity of services for access to core services for care, for symptom management, for support, for planning, and yes.
Please.
I'd like to just add for our viewers, palliative medicine is a branch of medicine just like cardiology, pediatrics, oncology. It's not like hospice care, or we tend to say palliative care, but it's actually a branch of medicine. And you don't have to be dying to have palliative care. You can have any illness in order to have palliative care. So I just wanted to clarify.
And then a follow-up to both of those is, since it is a branch of medicine, who decides who qualifies for hospice care and also for palliative care? And with that also, is there a point where it's too early to request hospice care, and is there a point when it's almost too late?
If I attentive. As far as who decides the timing of the palliative care, patients can request it from their physicians, from their primary care physicians, from their specialists that they're seeing. Let's say if someone has an advanced illness in terms of heart failure or a COPD, they may talk to their cardiologist or their pulmonologist and request a referral to see a palliative care physician. In terms of the timing and palliative care, there are more benefits when palliative care is introduced earlier on in terms of longevity and quality of life. In terms of what is the appropriate timing for hospice care, that really depends on the condition. It depends on whether hospice care would is it on? Okay. It depends on whether being on hospice care is going to stop certain essential treatments. For example, someone who is receiving care for cancer may be on chemotherapy, radiation, having some more invasive procedures that help with the disease and symptom relief. So for this patient, if they are still able to receive these treatments and they're getting benefit from them, then it will be too early to talk about hospice. For this patient, if for whatever reason they're no longer able to receive these treatments because they're too weak or the treatments may cause too much harm, and they want to focus more on quality of life and symptom management, then it would be appropriate time for hospice. And Alzheimer's is different. Or Parkinson's, or ALS, or COPD, or CHF. I think with these illnesses, if we've exhausted the medical treatments that are possible, and we want to continue those that are helpful, but we see that there's quite a bit of a decline, a very reliable marker for thinking about hospice is how often is someone going to go to the hospital to manage their illness. So if they're coming to hospital 3 times in 6 months, then that will be a question to talk to your doctor about. Where am I in my illness? Is it very advanced? Should I be thinking about hospice care so that I can have more support in the home where I can, the treatment can be more proactive so I can stay home more and not be in the hospital so much. Because as we all know, being in hospital is not great.
A lot of times families are concerned that they've heard that they would have to give up their primary physician. Is that still the case with hospice? No. Yeah.
I'd like to just add that what I see practically out in the field is that people wait too long to bring in hospice services. And enrollment in hospice is a bit onerous, and it's a big transition in a family's life. So it's much easier it's much better if you get on hospice earlier on, go through that registration enrollment process, and then you don't have to take advantage of all the services. Just take advantage of what you need. And then as the illness progresses, then you can take on more and more services. But if you wait too late, that transition can be really just a big burden. It can be a really huge change for the family, and it's really disruptive when you're at late stage illness. So recommendation is really get on hospice earlier and then just, go with it as the illness progresses.
That's a good question related to that.
Can you speak up so people can hear it?
I'd like to ask a question related to that. I found with my father recently, he died last April, and he was he had heart failure and end stage. But like I felt like his physicians, I mean, and he was going to the hospital frequently, but no one really kind of said or suggested, oh, you might want to think about hospice at this time. And I do work in a hospital. I am familiar with a lot of things, but and it's kind of hard too because the parents are kind of in denial about what's going on. And so, how do you bring it up with the primary physician, for example, or like how do you know when to do that? Because that's even as me, I work in a hospital, but I still didn't know how to do that.
Well, I'll just say quickly that I think largely it's because of the stigma of going on hospice, which is, the thought is if you go on hospice, then you're going to die. Or you're giving up. And so, the thing is that medical professionals and doctors don't tend to suggest it. And if the patient's family is not very informed about it, then it becomes this thing where it's never really brought up until it's too late.
So I have a question. So would it be appropriate in that situation to contact a palliative care doctor?
So there's no harm in asking to speak to a palliative care doctor because, or the team, the palliative care team can be very helpful in the hospital setting to help think about where the person is in their illness, to think about what can be expected, to explore the different treatment options, to explore the values of the patient and the family. So when in doubt, ask for palliative.
Someone in the chat asked, and you answered this already, but what are the signs to know when to begin hospice?
Yeah, so I think that was answered already about the signs of when to know to ask for it, but
there's a few other things in terms of signs. In general, for an older person, if they're eating poorly, losing weight, falling down a lot, or becoming bedbound, sleeping progressively more throughout the day, those are general signs that someone may be declining to the point of end of life.
Someone else asked what services are provided.
Sure, that's a great question.
Yeah.
The question was what services are provided with hospice care. So the services are pretty universal between the different agencies in New York. So first, there's nursing visits. So the nursing visits are typically once a week. If a patient is having a medical issue, concern, or the family is having questions or concerns, they can reach out to the nurse who's called the nurse care manager for the patient and request additional visits. There's also a on-call number or a hotline number. So if there's a problem at 1 a.m. or on a Saturday or on Thanksgiving or whenever, then family has access to advice and to have someone come and do an evaluation. There's a social worker who visits the patient anywhere between 1 to 4 times a month, but sometimes more often. And it really depends on the needs of the patient and the family. Some families don't see the benefit or aren't using the services. Others use the services a lot and may have more visits. The social worker helps with coping with the illness, legacy work, thinking about, the meaning that the patients have had in their own life, the impressions that they have left on others. They help with logistics like funeral planning, advanced care planning, working with other insurances like Medicaid to try to be an advocate to get more hours for home attendance. There's pastoral care, so They have non-denominational spiritual care, pastoral care that is available to visit patients. Not everyone wants that, but some people really benefit. There's typically a hospice physician, which was my role in my last job. So the hospice physician responds to or interacts with the nurse when they go in for the visits. The nurse reports what they are seeing, what the symptoms are. They come up with an idea of what the problem is and a plan. So they may decide, patient maybe is having a pneumonia. Let's have an X-ray come to the house, take an X-ray, or let's take some blood work. Let's start an antibiotic. Let's give a water pill because we think that someone is building up with fluid.
So
one thing I wanted to add about hospice services is that the one thing that can be misleading is the amount of home health services that you get. So it is covered by Medicare and probably other insurances, but the problem for many situations is that there's a limit of 4 hours a day, 5 days a week, and that can be increased with advocacy, I guess, but what I've seen is that's usually at the very end, and that in the interim period, we could talk about where other sources of coverage would come from, but I just wanted to point that out.
can you talk about what those are?
So in New York specifically, everybody does Medicaid planning. So that means that, and that could change in April of 2024, but for many, many years, you could not really have too many assets. In other words, as long as you had a person you could transfer the assets to, including your spouse, although that's a little more problematic, you could apply for Medicaid the following month, no matter how much money you transfer. So to do that, everybody who's going to do that should meet with an elder law attorney first, and then it's gotten harder to get the amount of care that you need, even with Medicaid, but it's still possible, and there are just ways sometimes you have to appeal, and it can take, in a hospice situation, it can take too long. There's actually a crazy thing where if you can get it expedited to a fair hearing, if the patient is homebound and the doctor says the patient cannot travel to a hearing, they can put amount of hours that are being requested before the fair hearing decision. So in a hospice situation, that would be crucial. But
I'd like to just mention 2 other services that most hospice programs offer that weren't mentioned. One is that hospices provide supplies, which are critical for caregiving. So supplies like a hospital bed, should that become necessary, as well as basic supplies like gloves, chucks, pads, ointments, diapers. No, some of them do. The second service is, many hospice services have volunteer programs so that you could have volunteers that come to the house, and that gives increased socialization for a person who may be confined to the house or ill, so that there's just, again, more interactivity and have, new faces, new people, and keep up their socializations.
I just wanted to quickly mention that hospice can be wherever your home is. So it could be in the apartment, in the house, in assisted living, or a nursing home.
Thank you. So I want to move away from hospice, although I recognize there may be questions that come up later, and talk a bit about the other housing that we're focused we've been focused just now on the very end in terms of care, but I think that there were some questions sent in around about other housing and various stages. So I was wondering, Stephen, I was asking you the question, but please others jump in when he's done, whether there are nuances people should know when considering the different housing stages, semi-supported, assisted living, nursing home, etc.
Sorry. So assisted living, I'm always saying, well, it's misleading. Well, so assisted living can be very good, of course, but it's very important to, and very hard to understand how you get the services you need and what it's going to cost. And the prices in New York City of these places range dramatically, and they're all going into the crazy prices. Like, I don't know, I should name any places, but there's a place in Brooklyn Heights where you come in and it's $15,000 no matter what you need. And then further out in Brooklyn, it's considerably cheaper, but the more help you need, the cost goes up very quickly. So if we're talking about end of life, we're talking about complete care usually at some point. So it can be misleading. Okay, assisted living, they're going to provide everything, but it's at a cost. So often, how would you decide that if you put the money issue aside, which is hard to do? You would look at, well, is this person someone who is a social person and wants to be around people, and there are people that were not like that, so they're not likely to be like that now. So, I don't know.
Yeah, so the question of housing for older adults comes up a lot for our program, and it's always been very interesting to me because I started my social work practice outside of New York City, and coming here to the city, you see housing is at a premium for everyone at every age. And so the landscape of housing for older adults, including supportive housing, is also very different. A lot of times I think that family caregivers, especially adult children of aging parents, they'll kind of have this impulse to say, okay, well, mom's been in her apartment. Do we need to find her a different place? I've heard, assisted living, just as Steve said, that sounds good. Nursing home doesn't sound so good, but maybe we should move her into a different place. And the reality here in New York City is that in the vast majority of cases, people just can't afford these assisted living facilities. It's stratospherically outside the budget for older adults and their families. The other option, nursing homes, a nursing home can often be the right fit for someone who needs that round-the-clock supportive care. There are some nuances in terms of who pays for what. Nursing homes are funded by Medicaid program, so they're federally regulated. It's pretty consistent from state to state the way that they operate. Assisted living, on the other hand, it's not funded by Medicaid, so there's no federal rules about what an assisted living facility needs to be or do. So just setting that out there too. But again, nursing homes can sometimes be the right fit, but the older adult really needs to need that level of care. There also needs to be, as Steve mentioned, in most cases, some advanced Medicaid planning, because ultimately Medicaid is going to be paying for that nursing home care. So for a lot of New Yorkers, the best care setting often ends up being in the apartments, in the homes that they've been living in. Now, that might require some changes in the home. It might require bringing in outside help. It might require doing some home modifications to make it safer. But oftentimes that ends up being the safest and the most cost-effective place for them to receive care.
And where usually they want to be anyway.
Good point. That too.
I meet a lot of families whose loved ones are coming to the hospital from a nursing home, and I rarely have a positive experience or hear positive stories about the care in the nursing home. I mean, there are situations where there's just no other safe option, and in that case, the best thing that the families can do is just to be a constant presence and advocate for their loved one, because that's the only way to assure some level of good care in these kind of facilities.
I have a question on the chat. How do you find a great quality nursing home studio or work? And are there resources out there?
So the question was, how do you find a great nursing home in
Yeah.
in Brooklyn, and are there resources for that? I have this one, Carrie. Again, lots of people come to our social work team with this question. They've been told that their loved one needs a nursing home level of care. Maybe the apartment home is just not safe or acceptable at this point. A nursing home is going to be the way to go. So how do you choose the right one? There are some resources out there. Again, because nursing homes are regulated at the federal level by the Center for Medicare and Medicaid Services, we have some resources online in terms of how those nursing homes stack up in their last cycle of inspections. So there's a star rating system that looks at staffing levels and when they came through and did that inspection, what did they see? Were there items that the facility failed? But even that star system, it's not, I wouldn't want people to rely entirely on that. Yes, so you can go to Medicare.gov and find this document. But I would, as I said, you can use that, but I definitely would stop there. I will also offer the caveat that for as long as I've been a social worker, I feel like for every family who comes to me and says, oh, Megan, this nursing home, they took the best care of my dad. They treated him like a king. Megan, you have to tell everyone to send their loved ones to, this is the nursing home to go to. I have another family who comes to me and says, Megan, that nursing home is awful. Don't send anyone there. So experiences vary. There's so many different factors that play into it. I really think that the very best thing that you can do as a family caregiver trying to make this decision is to personally go and visit those facilities. Check them out, show up, get the tour, see, how do things look? How do things smell? What is it like? I know it's terrible, but these are the real factors that you need to take into account. The other thing, and I almost hesitate to say this because I know that every family caregiver situation is different, and I don't want to put any guilt on anyone about this. But if you are able to choose a nursing home that you are going to be able to visit frequently, if you can find a place that, maybe it's not so fancy and shiny, but it's right down the block from where you live, and you're going to be able to be there on a regular basis, and you're going to be forming relationships with those staff members and letting them know that you're here on the grounds checking things out. In my experience, that's a very good predictor of what I would call quote unquote success with a nursing home placement.
I think there was a question on the list about caregiving from a distance. Yeah. And so along those lines, if you can't yourself as a family member be there, you can hire somebody to have the ability to do so, geriatric care manager, or perhaps you can even find another creative way of finding somebody just to be your eyes and ears. And I would say you got to go at least once a week because things can change quickly.
Yeah. And one more thing, because people will sometimes get nervous about this. Your loved one has the right to receive care in the setting of their choice as long as that is safe. So if you've gone through the work and you've got your loved one placed in a nursing home, you thought it was going to be good, and you find, hey, I really don't, this was not the place, we want to move them to a different facility. You always have that option. So you'll make this decision, but know that further on down the road, if you need to change things, you can.
So I'd like to switch gears again. Although I do the caregiving from a distance, I will say Megan and her team have a ongoing support group for individuals who are doing caregiving from a distance, and that can be somebody who's in Brooklyn caring for someone in California or the reverse. We do it all the time, and they do one-on-one support for that as well. So always a resource. I wanted to move now to Virginia. There were some questions around late stage death and what does that look like? What can people expect?
Okay, I'm not really quite sure what aspect of late stage death people might be interested in. I will say though, death for every person is different. Death is very unique. No two deaths are really alike because there's the age, the environment, the illness, the support system, their past history, their past medical history, their reactions to the illness. I mean, there's so many factors that even if you have the same illness and you're the same age and you're both men or whatever, it's unlikely you're going to have similar deaths. So deaths are very, very unique. But I will, in general, say that when you think about like that last stage and what death might look like, in order to die, both mentally and physically, you have to be ready. And in terms of the physical aspect, now I know as a family member, you already think your loved one is in a very diminished state compared to what they were in their prime or even just like a year ago. But in those last few days, in order for the body to physically prepare itself to die, it's going to change a lot. And that can be very dramatic. And that is something that people should be sort of like emotionally prepared for, that there could be, right, quite a lot of physical change. Now, it could be that somebody like looks fine that morning and dies that evening, and they still look great. But in general, like a normal natural death, there's going to be a slow breakdown of the body, and that it's going to be great physical change. And I think that's something that a lot of people are not prepared for, that when someone dies, they're like really quite a dramatic change in those last few days. And then just in terms of like mentally being prepared, that's really like, are you doing the mental work to get to that place where you can face what's happening to you and your own mortality in a peaceful, accepting state of mind, so that you're not struggling and that these, psychosocial issues are not going to result in a death that might have physical manifestations. So, you need to, death is not only just physical, like, the illness kills you in the end. I mean, you have to be mentally ready too. And so you have to do work as well. And if you can get sort of both of these things to get to a meeting place at the same time, where you're mentally ready and you're physically ready, then that tends to result in a fairly smooth death. In general, okay? In general.
And since we have caregivers who are listening, how do you recommend a caregiver prepare for that?
You know, those last days can be tough, right? Full of a lot of emotion, a lot of grief. You're already anticipating it. You know it's coming. It can be a really intense time. In those last few days, there isn't much physically that you need to do. I would say for most caregivers, it's the waiting that tends to be very challenging on an emotional level. And it's that just waiting, that waiting, and that waiting. So, you know, really it's about sort of making that most of that time with your loved one, even if they're in a non-responsive state. You can still talk to them, hold them, lie in bed with them. Still,
And it's okay to cry, right?
it's okay to cry, and it's, you know, still, you know, tell them everything that you want to say to them. I think that's probably the most thing, is you don't want to live with, I wish I had told them that, right? Say everything that you need to say. I mean, they might not respond, and they might not even comprehend, but they'll hear you. And the benefit it does for yourself to say these last words is just so meaningful. So, you know, make the most of that time in that quiet, moments of waiting. Really make the most of it and be together. And however long it takes, you'll have been there. And that's what's important.
I have a question on the chat. Someone's asking to hear more about end of life.
Okay, so one part of,
Just whatever question.
okay, so there was a question about how end-of-life doulas, their role might be at this time in life. So, I mean, end-of-life doulas can do many support services within the whole sort of illness journey. But in terms of talking about the very late stage or the end of life, we're often there to sort of like hold that space so that the family and the loved ones can have those quiet moments of being with their loved ones. And so that we're there doing the other things, you know, the logistics, the crap, or the answering the phones, or the coordination, so that the loved ones, the family, can be there with their together, right? Because what ends up happening is that, you know, there's so many things that need to be done or taken care of, and you get exhausted, and then all of a sudden you realize you've missed these special moments. And so it's really great to have that support service where you can be there, and you can have the end-of-life doulas sort of taking care of everything else. And also, you know, we tend to be, we're not in that emotion. We're not heavily carrying all that emotion, and so we're able to sort of step back and able to take care of a lot of the things that the family may find really challenging or difficult to do. And so the other thing that the end of life doula does, which hopefully we'll have done prior to those last days, is to really set the environment so that it's what the person who's dying wants at that moment. So what I always tell people is, the way I like to describe it is, look, if any of you are married or out there, right? When you got married, I'm sure you were involved in planning your wedding, right? You decided who was going to be there. You decided what the venue was going to be. You decided what the food was going to be like. You decided the theme and the mood, and whether there was going to be music, and whether there was going to be music. You didn't just like show up and like have someone else plan the whole thing. So if you're ill and you're dying, you should be planning this. This is the last big celebration of your life. You're not going to be actively participating, but you're going to be the focal point. And I have found that so many people, when they have planned all that, they go into those last days with that sort of really comfort, security in their mind that they know what it's going to be like for them and their family, even though they're not aware or they're not participating or they're not alert. They might just be lying in bed, but they'll have entered that stage knowing what it's going to be like. And it gives them such great comfort to face those last days when they've planned it themselves, they've determined it themselves. And so, you know, I say to everybody, think of this as like a celebration, and you don't want to just show up to somebody else's, you know, wedding. You want it to be for you, the way you can participate and make the most of it. And
I have a quick question related to that. I think this is a very interesting idea. And like, when would you normally work with someone on making these preparations?
months,
Maybe
years. Oh, so the question was, when would an end-of-life doula work with a client to make these preparations ahead of time? So it would be in advance. So honestly, if you're like contacting me weeks before you die, that's going to be pretty tough, right? Most of the times we're just trying to like make it not bad. But, you know, we're talking months in advance, sometimes even years. I mean, we would even prefer that you call us from the time of diagnosis, right? Let us, you know, begin the conversation. That's really what you want to do, is begin the conversation. And what ends up happening is that you end up being in control in the whole process. And you know what it's going to be like at the end. And that gives people such great comfort emotionally and mentally to go through whatever's happening to them medically and physically. And so that's kind of like ideally what an end-of-life doula does for patients, clients, dying people in those last few days.
Does insurance cover your services?
Our insurance does not cover our services at this point because actually our field is really quite new. I mean, we're not even 20 years old. Our field was only really founded in the mid-2000s, and we've only really become popularized since about 2015. And so, no, but it's not clear where our field is going in terms of insurance and reimbursements and what it is that we want. We're trying to do better than other professionals like birth doulas or, you know, other holistic practitioners. We're trying to figure out what would be the best way to fit within the system.
So actually, a question for everyone else. You know, Virginia spoke about supporting last wishes in the dying process, and I'm curious how each of you see your role in supporting not necessarily the last wishes, but the wishes of the person who is dying, and how do you forward that in your work?
So I typically meet patients who are very ill in the hospital setting. I like to meet with them and their loved ones outside of a crisis situation where we can think about what is going on with their illness. Are they going to be able to leave the hospital? If they can leave the hospital, where do they really want to be? And how they envision their end of life. Some people want a lot of aggressive medical treatment at end of life, and they are okay being in the hospital for a long time. They're okay being in an intensive care unit. They're okay, living on life support or with artificial feeding, and other people are not. So everyone has their own values and priorities, and my job is to help them sort of figure out what is most important to them and how to logistically make that happen.
So I'll just say to our listeners out there, last wishes doesn't apply to just medical. But, she's a doctor, so that's where she's speaking from, okay? But people only tend to think that wishes is about medical because they're so absorbed into being sick. They're so absorbed by their illness that all they think about is the medical aspect of it. But your wishes apply to, your emotional, mental wishes, your social wishes, as well as your spiritual wishes. And you can not only think about all these things, you can determine all of these things, and you can put all these elements into play at the end of your life. And if you bring all these wishes together and you make them happen for you, that's a good death, I think, right? Then that's meaningful for you. It's personalized, it's customized. You're bringing your values, your beliefs, what's important to you at the end of your life.
Okay, so I was thinking actually in terms of my own family when my father was dying, and he had very clearly made his wishes known about no feeding tubes, no extra life support kind of thing. But what we didn't anticipate was in his decline that he would become more childlike and start to think, well, maybe I should have feeding tube if the doctor says I should. And it was very hard for us to see. And, there are 3 kids, and one of them was like, well, maybe he does need the feeding tube, and then we finally prevailed because it was clear that he was dying. So that's just something that came to my mind. And as families, not everybody's going to be potentially not everybody's going to be at the same emotional readiness and may say, well, we're pushing for everything, and so it's good, of course, to know what your parents' wishes are before you get into that situation.
My role is a bit unique because for me as a social worker, it's the family caregiver who is my client, not the older adult who may be dying. So I'm a step removed from that person and from their wishes. And ethically, I have to center what my client's wishes are. My client is the caregiver. But Steve, as you were describing that situation with your family and your siblings and your father, we see that a lot too, where maybe one of the siblings is a caregiver client, we're working with that person, they're telling us, hey, I have this sister from California and she's flown in and she wants to change everything, or, hey, I'm caring for my parent and we've always had a difficult relationship. And my parents' end-of-life wishes are somewhat in conflict with my own values, and I'm not sure how to walk that line. The social workers on our team are here to support that family caregiver through those tricky dynamics. So we're not so much focused on the older adult, but we're focused on that caregiver. And in a lot of cases, it's wonderful that we have these medical teams and social work teams and death doulas and people supporting the person who's dying. But to have a social worker in the picture whose sole focus is on you, the caregiver, can be really helpful too.
I have a question in the chat that asks, what support is given to the caregiver after the person passes?
Yeah, so,
Repeat it.
oh, thank you, gosh. I thought, I really thought when that happened to me that I would remember and then I didn't. So I'm going to repeat the question. The question is, what kind of support is offered to the caregiver after their loved one passes away? So I'm going to speak broadly first, just because I know that people may be working with different agencies or in different parts of the country. You will find that these hospice agencies, these hospice benefits, they offer bereavement support as well as support during the dying process. So many of them have support groups. And in fact, I know that the hospice agencies here in New York City, their support groups are actually open to people regardless of whether or not their loved one was a patient of that hospice. So if you were recently bereaved, you can join this support group and get the support that you need. Oftentimes they will also offer kind of one-on-one grief counseling as well. So that could be something that if your loved one had, was enrolled in hospice, that you could access that. Even if they weren't enrolled in hospice, you could access a support group. For our caregiver program, the way that we at Heights and Hills handle this is we keep the caregiver's case open for 6 months after their loved one has passed away. And during that time, we're very upfront about the fact that, hey, we're social workers, we're specialized in aging, we're specialized in supporting family caregivers, but we are not grief counselors. But we will very happily make that referral for you for those bereavement, that grief counseling service when you feel the time is right. So we're kind of there to help transition the person from that intensive caregiving experience to what life is going to be like after the caregiving experience ends.
So I'll just speak for end-of-life doulas, and this is not necessarily for all end-of-life doulas because certain end-of-life doulas have different services. Now, I personally am involved in pre-death, during death, and I do provide post-death services too. So I do what's called early grief support, and I would say the primary difference in what I offer as early grief support is that as someone who was involved in the pre and during death, I have a shared common experience with the caregivers. And that allows me to speak, hear, like, how did you see what happened? This is what I saw. And whereas oftentimes when you go to a bereavement group. No, I mean, bereavement groups or support groups are great. Like bereavement counselors, like definitely, I'm totally supportive of that. But these are not people who were there at your loved one's death. And it's so different to be able to share the experience with other people who were there too. And so that's something that I always do, is really being able to sort of normalize, humanize what happened, because it was a shared human experience. And that allows the caregiver to then start really healing, because they're able to talk about it. They're able to express what happened to them. And we're able to share our experiences together and feel it. Because most of the times, a lot of people are very hesitant to start support groups because it's like, they might start, but then they don't speak, right? They go to the group and then they wait, they watch, and then, they wait till they feel like a level of trust and camaraderie with the other people, and then they might speak about their experience. And it takes time for that to happen in group. But support groups are great. And if you have really intense grief or prolonged grief, definitely you need to seek professional bereavement counseling, because they'll have more tools and methods and approaches. But for that early grief support, that is something that end-of-life doulas can be involved in.
Okay, a very specific question for you, Doctor. How do you recommend people handle dental issues that affect eating?
Dental issues.
I have cared for patients on hospice who've had dental issues, and eating is a very important part of caring and a part of life. And I think caregivers who see that their loved ones are not able to eat from something that seems fixable can be distressing or alarming. If your loved one is well enough to go to the dentist and have the work done to address the issue, then it should be addressed, because being able to eat is a part of quality of life. So as much as possible, it should be offered. I know that there are some dentists that come to the home and are able to provide certain services for homebound patients at a price, unfortunately. I've heard it's quite expensive, but it is out there.
I was just going to say there are.
Thank you. So we have a little less than 10 minutes left. So I just wanted to, maybe everybody could just take 2 minutes. And is there anything you weren't asked that you think people should really be paying? Oh, you have a quick, please go ahead with a question.
So I have a question about like when my mom's living by herself, she is losing her memory a little, and but so we want to get like a.
You know what? I'm going to have you speak into the microphone.
So my mother is living by herself now after my dad died, and she's losing her memory a little bit. She's still a lot. We manage all of her finances and everything for her, and we feel like it would be helpful to have someone kind of checking in on her, or maybe living in the house, maybe like a roommate. Maybe they pay a little rent, but then they get a discounted rent because they're going to check on her. I don't know what kind of a service would we look for, or is it a good idea to have like a roommate, or like we're not really sure how to proceed.
Most of the people who call me are in that situation, and so each person is different, but what we do in an initial meeting without your parents would be to find out, to brainstorm about what would make sense to her as to why this person is there. So you don't come at it from, well, you need help because you didn't do this and you didn't do that, and she may not remember what you're talking about. So instead, you make this a good thing. Like I had a situation today, and the phrase we came up with that I think is going to work is, you need intellectual stimulation. Because she probably thinks she's doing pretty well. Yeah. So you don't want to discourage that, right? So you want to enhance it in whatever way you can. So what I love doing in these situations is bringing in their paid people, but they come at like 4 hours at a time. And they are people, there's an agency that recruits people in the arts who want to do this in very small amounts. And it's hard to find people to do very little amounts of hours. So it's a perfect kind of thing. And these people are really smart, and they're good with their cell phones and iPads and things. So you can communicate in real time without mother knowing if there's some kind of blow up about something. And but also they can just bring out all the things that your mother would still enjoy but can't. So I don't know if I need to repeat that, but so they can help her keep involved in the things that she enjoyed before that she can't navigate anymore.
Oh, we've got another question live.
Not so much of a question. I'm coming back. I'm Susan Fox. I run Park Slope Parents, and I just wanted to thank Heights and Hills for making this happen because it's something that I've been wanting to do for many, many years. So one of the things that we will send around after is a set of resources that include things. We talked a little bit about the end of life. There's these 4 pamphlets that go through what to expect, things like the death rattle, and you're going, oh my God, what's a death rattle? There is a hospice nurse, Julie, if you know about her. She's great. She's on Instagram. We'll put her Instagram link, but she very clearly walks through this is what may be happening the last few days when you're watching your loved one die. And she normalizes it. And it's so now thinking about my mother going through this at some point, I have the tools. There's something called 5 wishes. Thank you. I feel like I have a cheerleader right here. So 5 wishes is a document. It includes a DNR, but it also includes things like how do you, if you're unable to say your wishes, do you want loved ones around? Kind of like the wedding idea. Are there people that you don't want around your bed? Do you want music to be playing? Do you want people to come together and sing songs to you? And once you go through this, I went through this with my brother went through it with my mother, and my mother's like, everybody should love each other. And my brother's like, I don't care. So it's a really important document that goes beyond your health proxy and goes beyond your DNR. So we'll send those resources around, I think, and then there's some books that people, Being Mortal is one of them, a lot of books about thinking about death. We're also going to be working with Greenwood Cemetery on some programming around kids and death. The Caregiver, the Family Dynamics Workshop that Heights and Hills has done for us in the past, we need to do that again. It's a wonderful, because we talked a little bit about the fact that, Bob doesn't want to put mom on life support, but Bill does. How do you negotiate that? And I think it's one of the best things I've ever seen you guys do, and you guys do everything well. So if you're at home and you're wondering, how am I going to navigate this? Call Heights and Hills. I know this sounds like a big commercial for Heights and Hills, but they're really amazing, and they have all of these resources. So I just wanted to give a special. Oh, big thing, the Caregiver program is free. So all of these resources are funded by other sources, so that when you're trying to hire somebody to come into your house, when you're trying to figure out how you're going to pay for it, you don't have to pay for these resources for caregivers. So I'll let you wrap it up, but I just wanted to come out and say thank you guys all so much for coming. It's a very, very hard time that many of us are going through, and you guys make it a lot easier. So thank you so much.
Thank you, Susan, and thank you for inspiring us to do this and pushing. I think it's been a wonderful evening and bringing up a lot for me personally, so thank you. So again, we have less time, but I still want to ask, is there something that you think you maybe didn't get to talk about that you think folks should know, or something that you did say that you want to hammer in there and say again?
The one thing I wanted to add is that hospice is also available in hospitals and specialized hospice facilities. Calvary is a very unique facility. They have campuses in Brooklyn and the Bronx. There's really nothing else like it. There are some kind of units in various places that try to mimic Calvary, but Calvary is really the very best for kind of inpatient care. And people have inpatient care if they have a lot of symptoms. So if they need to be on IV medications to be comfortable.
I would like to give one last piece of advice to caregivers out there, And the one thing that I would say to you is don't be afraid to ask for help. Okay? I know we are raised in a society that makes it seem like asking for help is a weakness, but it's not. Asking for help requires courage. It requires humility. And the ability to ask for help, it makes you realize that you're not alone in this world, that you're not alone going through this. It also creates community. It allows other people an opportunity to step up, to show their best selves, and to help you. And that we're all in this together as human beings going through common experiences. Ask for help. Don't try to just do it on your own. Don't try to just stick it out or tough it out. Caregiving was always a community-oriented activity, and we need to find that together again. So, please, you're not alone.
I guess what I'm thinking is it's really important to always allow the person that you care about to speak first before you tell them what needs to happen. Because you might be surprised that they're more open to it because you let them say it. They don't even know how they're feeling until you give them a chance to say it.
Virginia, you took the words out of my mouth. Yeah, there are very few absolutes, I think, in life, but definitely in caregiving. There's no one right way to navigate this. Every individual is different, every family is different, every relationship is different. And we're here to help. You know, this is why we are here. So please do feel free to reach out, whether that is tomorrow or next week or next year when you are ready. We are here with the resources for you as a caregiver. So please don't be shy.
Thank you. Thank you again all for taking the time. Thank you again to Susan for inspiring us to put this together, and to Kathy for running the Zoom. And I also want to echo that not just asking for help, accepting help when offered. It's been my New Year's resolution, a year that is almost over. I'm fairly better at it. But when accepting help, asking for help is great. Accepting help when offered is even harder. It's even more special for the person who's offering it, and often can be even more rewarding in receiving it because you didn't think to ask for it yourself. But when somebody shows up with cut fruit because they didn't know what else to do, it's like, oh, I don't have to cut the fruit, thank you. So take it when it's offered. Thank you all again for taking the time. We'll have all of the resources that Susan mentioned. We'll have contact information for everyone on the panel, and we have recorded this so you can watch it again, or you can point a loved one to watch it, and hoping that this was helpful. Thank you.